Welcome to this e-seminar organized by the Immunonephrology Working Group of the ERA-EDTA. Today we're going to have a session on the greatly anticipated revised KDIGO clinical practice guideline for glomerular diseases. And we have a distinguished speaker and panelists today. The speaker and the lead for this monumental work is Professor Jürgen Floege, who's a professor of nephrology and immunology at the University of Aachen, Germany. He has close to 600 original papers and reviews and editorials, and is an expert in immune-mediated kidney disease. Then we have as a panelist Professor Vladimir Tesar, who's currently the chair of the Immunonephrology Working Group, the professor of nephrology at Charles University, Prague, Czech Republic, and has a long-standing interest in immune-mediated kidney disease, ANCA-associated vasculitis, and lupus. And finally, Professor Gema Fernandez Juarez, who is the head of department at the University Hospital Fundación Alcorcón in Madrid, Spain. And she's also a board member of the Immunonephrology, which Jürgen Floege is as well. And she has recently published as lead author the Starman trial on membranous nephropathy, which was partly founded by the ERA-EDTA. I just also want to inform everybody about participating live. The participant will earn 1 European credit for the continuous medical education, and this is an exclusive benefit for ERA-EDTA members. And to receive your benefits, your credit, you have to answer a short survey at the end of the seminar, and I will remind you of that. So please, Professor Floege, the floor is yours.
Thank you so much, and thanks for the kind introduction. Let me just share my screen. So here we go. As Annette Bruchfeld said, this is the long-awaited but mostly really overdue update on the KDIGO practice guidelines on glomerular diseases. And if I can give you some personal advice, if you're ever asked to coordinate this, don't do it. This is by far the biggest guideline that KDIGO produces, and the original text is now more than 600 pages long. So it was a lot of work. So to start out with, these are my disclosures. I have consultancies for various companies, many of them involved in the treatment of glomerular diseases. And this is how it all started. This KDIGO typically has a controversy conference. This is about 4 years ago when we met in Singapore. You can see there were more than 100 people, and you discover some really well-known faces on this slide. So essentially, this whole conference was about looking at the 2012 guidelines, which really reflected the knowledge up to 2010. This is how old they are. And then to check each statement in the old guideline, whether it needs a revision. And you can see the red ones are those that don't need a revision. And I guess you can immediately sense why we had a massive task. And Vladimir Tesar can, of course, who's a member of the working group to revise the guidelines, can, of course, comment on this as well. Now, KDIGO guidelines, just as a quick reminder, use the GRADE approach. GRADE has 2 levels. Level 1, we recommend. Most people in your situation would want the recommended course. Level 2, we suggest. Majority would want to do that, but many would not. So this is important to keep in mind. A level 2 suggestion is not a must do. And then each recommendation is graded by A to D, depending on how certain we are And the fortunate situation is that in the year 2021, we have many more trials compared to 2010 when we did it last time. A new feature in the KDIGO guidelines, in all KDIGO guidelines, will be so-called practice points. Practice points, here's a nice illustration, a practice point. The evaluation of kidney tissue should meet standards of biopsy adequacy. This seems trivial, but we as a group felt it's important to give this, this advice. It certainly is not a guideline, and it never will be. There will never be a controlled clinical trial on how much kidney tissue do you need. So we feel these are a welcome addition, in particular in areas where we have little evidence, but where we would probably all love some common sense, and better to have that from experts than everybody doing what he or she feels is best. And another new addition that is about to come will be Magic App. Magic App, as you can see from the text here, is a Norwegian app that was designed for guidelines. So you find lots and lots of guidelines in there, and KDIGO will use Magic App to make this in an app format. And the other thing I can promise is it will not take another 9 years for the next update, but rather KDIGO will try to do annual updates, much smaller, of course. But this app in particular will allow us to be much more flexible compared to, let's say, a 650-page document. So these are the topics that are in the guidelines. We had long discussions. We were asked, well, why don't you include Alports? Why don't you include this and that? But this is what the group finally ended up in terms of diseases that we cover. And you can see these are a huge number of diseases, in particular when it comes, for example, to infection-related, complement-associated, or diseases with an Rpgn pattern, for example, where lots of different diseases are. So only just the executive summary is about 60 pages. And again, it tells you how much stuff is in that guideline. Today, given the short time that we have, I will focus on these 4 entities, which covers most of the diseases we see in adults with glomerular disease, immune-mediated glomerular diseases. So obviously IgA, membranous minimal change in Fsgs. And since I'm an adult nephrologist, I will focus on adult diseases. Maybe we need another seminar to focus on children. And I will briefly cover ANCA and lupus. So let's start with IgA nephropathy. The practice point number 1 is, of course, on prognosis. And we suggest that if you want to talk to your patient about prognosis, you use this risk prediction tool. It's freely available at this website called QXMD. But the important thing to keep in mind is that this prediction tool can only be used at the time of the kidney biopsy because it requires the MEST score. And it shouldn't be the MEST score 5 years ago, it should be the current MEST score. And we also feel it's important to stress that this cannot be used to determine the likely impact of treatment regimen. This is based on retrospective data, and you shouldn't use it to decide, let's say, do I want to give immunosuppression or not? And finally, this prediction tool only works for about 6.5 years because it wasn't validated for extended periods, which of course is a downside. And we also make the point that except for kidney function, GFR, and proteinuria, there are no validated prognostic serum and urine biomarkers, which is really an unfortunate situation because after all these years and many, many, many papers, we still cannot really assess disease activity in IgA nephropathy other than proteinuria and GFR. Next point, considerations for all patients. The primary focus should be management should be optimized supportive care. And I've listed all the measures down here that I go over with in my patients. And I suggest you use this table because it's always fascinating. I see lots of second opinions referred to me by other nephrologists. Nothing against my colleagues, they're brilliant. But it's amazing that if you really take the time with a patient to go over this, how much you discover that can still be optimized. And I would rather optimize anything of this list than thinking about cytotoxic therapy. So this should include giving lifestyle advice on a diet, smoking. If you smoke and have Iga nephropathy, your risk to reach dialysis increases tenfold. It's massive. Weight control. Patients hate me for that. But I see a lot of second opinions coming in with the question, should I get steroids because I have 3 grams of proteinuria and in comes somebody fairly obese? What is the likelihood then that you cure obesity with corticosteroids? And I tell them, look, you got to lose weight. Here's the first recommendation. We recommend that all patients with proteinuria, and note this, above 0.5 grams per 24 hours, irrespective of whether they have hypertension, should receive a RAS blocker, a very strong recommendation. It's particularly important for countries like Korea and Japan, where you cannot prescribe an ACE inhibitor or ARB unless you have overt hypertension. So we were trying to give these colleagues some political strength, but the other important thing to stress is that essentially when you have any proteinuria, we suggest you give a RAS blocker. And it's only patients who remain at high risk despite maximal supportive care, and maximal supportive care is more than giving an ACE inhibitor. As I said, it's an extensive discussion of lifestyle. Only if you are still at risk, you should consider a 6-month course of corticosteroids. And the new issue here is that you have to discuss the important risk of treatment emergent toxicity, in particular if your GFR is low, because adverse events really increase. Adverse steroid-related events really increase if your GFR is low. And you should use extreme caution or avoid corticosteroids completely if the GFR is below 30, and this is not rapidly progressive glomerulonephritis. If you have diabetes, and look at this, if your body mass index is above 30, use extreme caution or avoid steroids. And it makes sense. You don't want to treat obesity-related hyperfiltration and proteinuria with corticosteroids. And all the others, I think, are fairly self-explanatory. Now, this is reinforced by the long-term outcome of our STOP IgA trial, where we had compared supportive care, optimized supportive care, with supportive care plus immunosuppression. The original trial lasted 3 years and showed there's no difference between the 2 arms, but we were criticized that 3 years is short for an IgA trial. So we found the patients again, and we found 92% of the patients after an average, a median follow-up of 7.4 years. So the real long-term, non-interventional, just observational follow-up. This is what we found. 70% of my patients had an event. And the event here is a very hard endpoint: death, dialysis, or GFR loss of 40% or more. So despite optimized supportive care, you can see that a lot of my patients were high risk. They lost more than 40% of GFR, which had been another criticism of the original Stop IgA trial, that maybe we had looked at a low-risk population. No, it was a very high-risk population. And this, I think, is the best piece of argument that we have why we need better, safe, and effective therapies beyond what we have today. Let's switch topics. Membranous GN. Practice point number 1. In patients with membranous, use clinical and lab criteria to assess the risk of progressive loss of kidney function. And I'm just selecting one. There's a very controversial practice point in the guideline which says if you're PLA2 positive, antibody positive, and you are nephrotic and the setting is right, you no longer need a kidney biopsy. That raised a lot of discussion and will continue to raise a lot of discussion. But these are the 4 groups we are proposing. You're at low risk if you have normal GFR, non-nephrotic proteinuria, moderate risk proteinuria above 4 grams, and no GFR decline. High risk, your GFR is already reduced, you are massively nephrotic, you have high titer antibodies or low molecular weight proteinuria. And this is an important group, the very high risk group, which has life-threatening nephrotic syndrome, rapid deterioration of kidney function, or very high low molecular weight proteinuria. And I will come to this because this is what should guide your treatment. Here's the 1B recommendation. For patients with membranous and at least one risk factor for progression, we recommend rituximab or cyclophosphamide and steroids for 6 months, or a tacrolimus-based therapy for at least 6 months, with the choice of the treatment depending on the risk estimate. And this is where the risks recur. So if you're low risk, it's okay to wait and see. Moderate, you can wait and see or use rituximab or calcineurin inhibitors. High risk, rituximab or cyclophosphamide, the so-called Ponticelli regimen, where you switch chlorambucil to cyclophosphamide. It's oral cyclophosphamide. Or, and I guess Gema will talk about this, calcineurin inhibitors combined with rituximab. And please note the very high risk group. It only recommends cyclophosphamide. And this is important to keep in mind. If you lose kidney function very quickly with membranous nephropathy, or you have life-threatening nephrotic syndrome, only cyclophosphamide has been proven to prevent dialysis. Rituximab and calcineurin inhibitors have not shown to prevent dialysis. So for the time being, this is a group that still requires the so-called Ponticelli regimen. One of the key studies influencing the guidelines was the Mentor trial, rituximab or cyclosporin in the treatment of membranous nephropathy. And rituximab was given, and I think this is important in membranous, 2 grams, one on day 1 and one on day 14. Don't use schemes that use less rituximab, because in nephrotic syndrome, you have significant loss of rituximab in the urine, of course. And what Mentor showed is that partial or full remission at 1 year was not different between the 2 arms. So the cyclosporin was just as effective as rituximab. But then the maintenance of remission was much better in the rituximab arm, whereas patients with cyclosporin really had very little persistent remission at 24 months. Now, the unfortunate design of Mentor required that therapy was ended, therapy had to be ended at 1 year. And of course, when you stop therapy here, the cyclosporin group will quickly relapse, whereas the rituximab group, of course, has some continuing treatment effect. So it's a little bit a comparison of apples and oranges. Another practice point, very important, and this is novel compared to the old guideline, longitudinal monitoring of phospholipase 2 antibodies at 3 or 6 months after start of therapy can guide your treatment. And we know now from many studies that antibody levels change much quicker than proteinuria does and are much more sensitive. So when you measure antibodies at 3 months and they're absent, you can, it allows you to consider stopping treatment. And if they are still absent then at 6 months, then continue with a wait and see policy. On the other hand, if they increase despite your initial treatment with rituximab, CNI, or cyclophosphamide, you may need extra doses, you may have to consider different treatment, or you may even have a patient who is resistant. Minimal change and FSGS. A recommendation for minimal change in adults, high-dose oral corticosteroids for initial treatment, a 1C recommendation, unless you have contraindications, in which case you can use cyclophosphamide calcineurin inhibitors or MMF. And the next recommendation is to use cyclophosphamide, rituximab, calcineurin inhibitors or MMF analogs for the treatment of frequently relapsing or corticosteroid-dependent minimal change disease, a 1C recommendation. This may change, and this is why I believe it's important that we now have annual updates, because just a few weeks ago, at the end of 2020, this British trial was published where they compared prednisolone and tacrolimus in adults with minimal change nephropathy, and the achievement of complete remission was no different between the two arms. And then after you achieved remission, the treatment was tapered, and you can see the bad news is that both really relapse frequently, but it's again, no treatment-related difference between tacrolimus and prednisolone. And if I were a patient myself, I'm not certain I would want to have high-dose corticosteroid therapy if the alternative is tacrolimus. Adverse event rates were comparable. Here's FSGS. We consider, if you have an FSGS lesion on the kidney biopsy, we consider 3 different scenarios. Scenario 1, you're youngish and you have nephrotic syndrome. This is likely primary FSGS. The other extreme is you have no nephrotic syndrome. This is likely a secondary form. For example, it could be obesity related or whatever secondary mechanism you have. We consider genetic screening only if there's a family history or a suggestion of a syndrome in adults. Do not start immunosuppression, use supportive therapy, in particular RAS blockers, and monitor. And the same would be true for patients with proteinuria above 3 grams, but no nephrotic syndrome. If these patients worsen, then consider immunosuppression, and immunosuppression should be high-dose corticosteroids as first-line treatment, lowish level of evidence. Anchor vasculitis. This is the treatment tree, in a way, of how these patients should be managed. You diagnose them, you assess disease and disease extent, you try to induce remission, and for that, the guideline will recommend cyclophosphamide and glucocorticosteroids, or rituximab and glucocorticosteroids if you have kidney involvement. Recommendation is to use either of these 2 treatments as initial treatment of new onset anchor-associated vasculitis, a 1B very strong recommendation. If there is no organ-threatening involvement, consider methotrexate, usually not a good choice if there's kidney disease and in particular kidney failure. MMF may be an alternative. Plex, plasmapheresis, I will talk about in a minute. Once you have disease control on drug, you should go to maintenance therapy and then consider azathioprine or rituximab, and then consider this as a long-term maintenance therapy. And finally, you have to decide to take patients off. So the recommendation here is we recommend maintenance therapy with either rituximab or azathioprine and low-dose glucocorticosteroids after induction of remission. Pexivas, I just mentioned this, has really influenced the guideline. 704 patients, 18% severe, and a median creatinine which was already pretty low, pretty high, so the GFR was low, 20% were dialysis dependent. They had two approaches, and they used either no plasma exchange or plasma exchange. Plasma exchange was not effective in preventing death or end-stage kidney disease. And I think the most interesting arm was the other arm on corticosteroid dose. So the guidelines will be relatively reluctant to recommend plasma exchange, and maybe we can discuss whether there's still an indication for this or not. The interesting observation was that compared to the full dose corticosteroid regimen, the 50% regimen was just as effective. And it was not only effective, but the key important thing is down here, where the risk of serious infections at 1 year was 30% lower compared to the high dose regimen. And if you, these are the reduced corticosteroid regimens. If you take, for example, a 70 kilogram person, you start high, but you can see that already at month 2, you're down to 15 and you go down fairly rapidly. And finally, lupus nephritis. A 1C recommendation, all patients with lupus nephritis should be treated with hydroxychloroquine or an equivalent antimalarial unless contraindicated. This should be baseline therapy for all. If you're class 1 or 2 and have low-level proteinuria, extrarenal manifestations should guide your treatment. If there's nephrotic syndrome, evaluate for podocytopathy and treat as minimal change. The most common class you and I probably see is class 3 and 4, where we recommend that patients with active class 3 and 4 with or without a membranous component, so a class 5 component, should initially receive corticosteroids plus either low-dose IV cyclophosphamide, the so-called Euro-Lupus scheme, or mycophenolate analogs. And that after completion of initial therapy, these patients should be placed on mycophenolate analogs for maintenance. Class 5, low-level proteinuria, essentially use RAS blockers and only use immunosuppression if there's extrarenal manifestations, and of course hydroxychloroquine. If they are nephrotic, RAS blockers, and then you have a choice of glucocorticosteroid combined with any other agent that is listed here, essentially all of them. And of course, hydroxychloroquine. So in a nutshell, that was what you can see in writing, and it will appear in September this year in a Kidney International supplement. And at the same time, we will provide the executive summary in the regular issue of Kidney International. So that was it from me. Thanks for listening, and I'm very happy to take any questions.
Thank you very much, Professor Floege. So for questions, all the participants are advised to write their questions in the Q&A box, and we will try to answer them. So now I'd like to move on to our panelists for their comments. And I will start with Professor Gema Fernandez Juarez regarding your comments and perhaps especially around the suggestions about the membranous nephropathy, what your thoughts are.
Okay, thank you, Dr. Floege, for your nice talk. Everyone have learned a lot. So maybe you say and you describe very well the graph of the mentor study and how patients who receive treatment with cyclosporine after month 12, the relapse rate was very high.
Yes.
So maybe I missed in the recommendation that how to taper the cyclosporine or the calcineurin inhibitor, or maybe, of course, the statement wasn't published in this moment, but if you, I ask you, if you use calcineurin inhibitors, you think that you should use rituximab after finish the treatment, because we can't forget that Starman used tacrolimus only for 6 months. In Mentor was 12 months, and even in this situation, the relapse rate was incredible higher in Mentor study. And I think the difference was the use of the only one dose of rituximab.
Yeah. I mean, the guidelines will stay vague about what to do when you want to taper treatment. And maybe you can comment a little bit about your interesting approach on using tacrolimus and rituximab combined. I mean, the rationale is clearly there. It seems that calcineurin inhibitors can keep the disease under control, but only as long as you treat. We have no good recommendation of how you should stop the treatment. If you give a calcineurin inhibitor, whether it makes sense to reduce to 50% or whether you just stop. I don't think any trial has looked at it. But what is certain is that the calcineurin inhibitors only work as long as they are given. And if you remember the British Lancet study on high-risk patients with membranous, the calcineurin inhibitor, they used cyclosporine. It was completely ineffective in very high-risk patients. And that's, again, something important to keep in mind.
Gemma, you need to unmute.
Again, about membranous nephropathy, in my opinion, we are trusting too much in the PLA2R antibodies. When patient responds, the concordance between immunological and a clinical response is very good. But when the patient doesn't respond, the concordance is not very good. For example, in the Starman study, 50% of the patients who don't respond to the treatment achieve immunological response. So maybe if you guide your therapeutical decision only with the PLA2R antibodies, maybe you can be wrong.
Yeah, well, this is why this is a practice point. It's not a recommendation. and why the practice point still is somewhat cautious. We say it may be useful. Clearly, this is a very dynamic field, and I absolutely agree with you that not every change in the antibody titers is a meaningful one and should have a diagnostic, a therapeutic consequence. So clearly this can only be part of the clinical decision making, but it shouldn't be the only way to decide. The other thing to keep in mind is, and we had a long discussion on this, that these assays are still not standardized. So make certain that if you use it to guide your treatment, that your lab doesn't change the assay. Often they do without telling you. And of course, you can only compare one assay with the same assay.
All right, thank you. I think I will direct the next question to Professor Tesar, and that's about one question is, what is the argument for plasma exchange in renal ANCA-associated vasculitis, as Pexivir showed clearly no effect? And the other one is, if you have any comments considering pathohistological findings for plasma exchange, if that would be a strategy.
I mean, right now there's a lot of uncertainty around plasmapheresis, and the guideline certainly doesn't give a recommendation. We were all, in a way, a little bit afraid, and Vladimir, correct me if I'm saying anything wrong. Vladimir was part of the anchor group. I guess, were all a little afraid of completely abandoning it and giving the advice, don't use it. Because Pexivir had only 20% of patients with severe pulmonary hemorrhage. And we still use it if there's severe pulmonary involvement, patients are bleeding from the lung, we still use it.
If I can comment on that, so I completely agree with what was said by Jürgen. It's probably too preliminary to come to some final conclusions. We still expect the published meta-analysis of previous studies, including Pexivir, and we still wait for secondary analysis for Pexivir trial, because it was already shown in previous trials, such as in MIPEX, that plasma exchange has no effect on mortality, but it may have some probably only more temporary effect on the risk of ESRD. And it could have been demonstrated also in Pexivir in a subgroup analysis, but the data are still not yet available. And the second important point is what also was suggested by Jürgen, and it was also the experience in my department when we had, I think, 10 patients in Pexivir trial, that we were so sure that plasma exchange is good for the patients, that when we had the patient with severe alveolar hemorrhage or with quickly progressing renal disease, we treated and did not randomize the patient for the trial. So it means that in the trial, there was a selection of patients with not so severe disease, and it must also be taken into consideration. And the last point is that there are some patients who can't be treated, for instance, with cyclophosphamide because of the concomitant infection, and you have very limited option what to do, but you can still treat them with plasma exchange because it's relatively safe. So I think that there probably will be some space for plasma exchange, but it needs to be defined.
Yeah. So I think for the secondary outcome, there will be some pathohistological data to see if there is any signal there for more severe kidney disease. So there are many questions. Now there's one question about any change in recommendation on the duration of therapy in ANCA vasculitis and lupus nephritis. That's a broad question. We'll start with ANCA vasculitis. There's this slide that Jürgen Floege showed, but it said that you had to taper, but there was no information exactly when. What would you say, Professor Tesar, about that?
If I can comment on that, there was a long discussion if all patients with ANCA vasculitis are to be treated in the same way, and if the treatment should not be more personalized, and I'm almost sure that it should be, but we have unfortunately limited data to demonstrate it and to have an evidence for that. So clearly the patients that PR3 positive ANCA should be treated in different way compared to MPO positive patients. There was even a suggestion that some MPO ANCA positive patients do not need any kind of maintenance treatment. And on the other hand, rituximab is probably much more effective than PR3 ANCA positive patients, and it is not necessarily to be used in MPO positive patients. So for the future, I think that there will be a trend to more personalized treatment, but unfortunately it is not easy to implement it in the guidelines because all previous studies starting from the 1990s until now combined MPO and anti-PRC patients together. So they were even not a stratification. So it's very difficult to dig some data from RAVE trial, for instance, showing that there is a difference, but this is only a secondary analysis, which of course doesn't have such a high value. So in the future, I think that these patients should be treated in separate trials and should be treated in different way.
Okay, thank you. So I would like to ask, because as Professor Floege pointed out, that there will be mechanism for update of the guidelines, and right now there are many clinical trials who are recently published in immune-mediated kidney, and there are lots of studies ongoing in Iga Nephropathy, a lot of complement modulating drugs that are tried. And one question here is maybe around belimumab, if you have something to comment about the new trials, and also voclosporin for lupus nephritis, if that will be.
Yeah, both of these, of course, are very interesting for lupus nephritis. Both of these are not in the guidelines because the evidence review simply had to stop at one point. And in both cases, I'm 100% certain that in a year from now, we will update the guideline and include voclosporin and belimumab.
Yeah, I can also comment, there is a renewed interest in B-cell depletion or B-cell modulation in lupus nephritis, and is based on, of course, BLISS-LN trial with belimumab, but also on secondary analysis of LUNAR trial showing that if B-cell depletion is really achieved, the drug is effective. And the third trial, which also showed the positive results, is the phase 2 trial with obinutuzumab called Nobility. So we have some strong data showing that B-cell depletion or B-cell modulation may be effective. But what is currently not clear is what is the exact place of this drug in the treatment of lupus nephritis. Probably they are not in the first line.
And they are certainly, not only probably, but certainly pretty expensive.
Yeah, of course.
Cost is always an important issue. So for ANCA vasculitis, with this new development of complement receptor inhibitor, so I understand that you had to draw the line somewhere, but this is a very exciting development. And of course, we don't know anything about cost, but still, what is your view on the role of this type of drug in ANCA vasculitis?
Fantastic new approach. I heard, I haven't seen this in writing, that despite all of us being really excited about this approach, the FDA didn't grant a license. I don't know the background. Vladimir, do you know anything about this?
I also do not know the details, but the situation is that the scientific committee did not recommend to give the license, and the FDA will only decide. So probably they did not take the final decision, but of course they usually decide based on the recommendation they get. And I am not quite sure why they are not very much happy with that. I think that one reason is that it is only a non-inferiority trial, because FDA was always interested in showing that some add-on treatment improves the outcome of the patient, which is not so much the case. But although there were some positive effects on the glomerular filtration rate in avacopan trial. But in my opinion, we need to replace old toxic drugs such as cyclophosphamide and corticosteroids with newer ones such as rituximab or avacopan, even if the treatment is more effective. And I think that compared to, for instance, treatment of cancer, the treatment in vasculitis is much more cost effective. because usually there is a long-term efficacy. The patient return to the normal life, they can work. So it is still not so much expensive treatment, but of course concerning avacopan, we do not know the cost, and so it may be a problem for some patients, yeah, and for some countries.
Just
Vladimir, do you think that the average of glomerular filtration recover is only between 3 and 5 milliliters per minute? Don't you think is very low? So any drugs, any adverse events only for these modest effects in the glomerular filtration? What is your opinion?
You mean with avacopan?
Yes.
I think that the major contribution of avacopan is not this difference in eGFR, which in my opinion still may be important for the patients. The major difference is that the efficacy is very quick. So the effect is quicker than with corticosteroids, and then you can avoid the toxicity of high-dose corticosteroids. Of course, the way which is less expensive how to avoid toxicity is to use the regimen which was used in Pexivas. So very quick tapering of corticosteroids, which is definitely recommendable with the data coming for Pexivas.
I mean, one key aspect, and I very much support Vladimir here, one key aspect that no studies so far conquer is the 10-year, 20-year risk of malignancy, 10, 20-year risk of cardiovascular disease, bone disease, etc. As Vladimir said, I'm very unhappy that we cannot have these new therapies enter the clinical scheme when we're all concerned about very long-term toxicity.
So in fact, there are data showing that rituximab is not associated with the increase of cancer.
Yes.
This is what we already know.
But there's no formal trial, of course.
Yeah, of course.
But the data is very convincing that a long time after cyclophosphamide, you see more cancer.
Of course.
So I want to move back a little bit to membranous nephropathy and Gema. There's a question about how important is plasma cells as a potential cause of refractory membranous nephropathy. There are case series where the use of bortezomib and daratumumab anti-CD38 have shown benefit. I think the KDIGO guidelines have not emphasized refractory cases.
Well, maybe to jump in first,
Yes.
what we say for refractory cases is refer to a specialist center, full stop.
Yeah.
That's right.
Don't try yourself.
No. So Gema, you have to unmute.
Gema, you're muted.
Okay. Maybe rituximab, I think, is very good. And maybe the new anti-CD20 is good as well. But again, like Piletuar, I think we are trust too much in this kind of drugs. I think that daratumumab maybe can be a little better than rituximab, but in my opinion, no much more better. In case of relapse, maybe always to use cyclophosphamide and maybe use plasmapheresis in some cases, especially when Piletuar are involved.
Thank you. Now just one question about, again, about ANCA vasculitis. How about patients with serum creatinine of more than 5.7 and that have cellular crescents with not much chronicity? What is your opinion about the optimal treatment, and does that include plasma exchange?
So if I can answer, so definitely these patients should be probably not treated with rituximab only regimen, because we have limited data that rituximab is really working, although it may work. And what is usually recommended is to treat a patient with either the classical treatment with cyclophosphamide or at least with a combination of cyclophosphamide and rituximab. as it was in Rituximab trial. And in fact, I would add also plasma exchange in these patients with very severe and active disease. But this is really now not so much based on evidence after Pexivas, I agree.
So in this point, I think the guideline include that in very ill patient, in very severe pancreavasculitis, we can use triple therapy with corticosteroids, rituximab, and cyclophosphamide, because we can forget that one of the study to open inducing rituximab in vasculitis induction use 2 doses of cyclophosphamide at the beginning. So maybe, and we know the British study, they show that the triple therapy is even more than corticosteroid and rituximab. So maybe when we have very severe ANCA-vasculitis, we can consider the plasmapheresis, but we can forget use the 3 drugs.
Yeah, so the comment to that, of course, the regimen suggested by Dr. Pepper with combination of cyclophosphamide and rituximab is meant mostly to reduce corticosteroids. So this is the main aim, but they were effective. Yeah, they were really able to reach that. And the second point, we published a paper several years ago with Dr. Gita, Dr. Gita and her group were the main authors, showing that even if you treat the patients with very advanced kidney failure with rituximab only, it seems to be effective, but these were only retrospective data. And of course, the quality of the data is much lower than if the data come from clinical trial, but it may be a good option in some patients who can't be treated with cyclophosphamide, for instance, because of concomitant infection.
Yes. So thank you. There is one question for Professor Floege about if you would like to comment something, any comments on budesonide in IgA nephropathy, phase 3 study?
We need to first distinguish, do we talk about budesonide or do we talk about encapsulated budesonide? Pharmaceutically speaking, these are different. The drug that is currently being in a phase 3 trial is a particular encapsulation so that the budesonide is released mostly in the terminal ileum, which is very different from the, let's say, conventional budesonide that we have. The phase 2 data looked very positive, but the phase 3 study is ongoing. There was a press release that proteinuria was nicely affected by this, but this is all you can say about the approach today.
Any other comments regarding this? So no, I think you're right. We have to wait for the final results of the study. So now there is one question that several people have asked, and that is about the SGLT2 inhibitors for glomerular diseases, and especially for IgA nephropathy. What is your view on that? Is that something we should consider, or should we do something else?
It's a difficult discussion. And I would refer you to the Kidney International editorial that Jonathan Barrett and I have written on the DAPA-CKD data in IgA nephropathy. First of all, this is a very interesting approach. And I think the key important aspect in IgA nephropathy is that it's safe. The risk of ketoacidosis is very, very low. And I guess since you don't induce massive glucosuria, the risk of genital mycotic infections is also very low. It's not specifically evaluated. The benefit from dapagliflozin that was reported was outstanding, a 75% reduction of the primary endpoint. But Jonathan Barrett and I were a little concerned that, first of all, there was a blood pressure difference between the two arms. And mostly we were concerned that the placebo group did very badly, much worse than you would have expected based, for example, on the prediction of the calculator. they had a 24% event rate over 32 months. And the calculator, depending on ethnicity and circumstances, would have predicted 7 to 17%. So the concern is that the benefit was a little exaggerated, maybe because of insufficient supportive therapy, established supportive therapy, but it doesn't take away from the fact that this is safe and probably very effective therapy. And yes, I'm using it already, but I'm very eager to see the data of the EMPA kidney trial with empagliflozin that will be published next year in the same setting, diabetes and non-diabetes.
And in that trial, they even include patients who have very little or no proteinuria. There is a,
Correct.
which is very interesting and will guide us. Do the other panelists want to add something regarding SGLT2 inhibition for other indications also in glomerular disease?
I would like to highlight the Fsgs in the guidelines, because I think it's one of the more important change respect to the previous KDIGO guidelines, because in the all guidelines we only occupy about idiopathic FSGS, and now we occupy about all the FSGS, and I think it's a very necessary exercise, because there is a big confusion about the difference between primary, secondary, and genetic form, and I think the discussion about this difference between these three forms is very important. It's very important because Dr. Floege talk about second opinion. Every day I see patients with secondary FSGS with immunosuppressive drugs. So it's a crazy situation. So I think it's very, very important the discussion that the guideline has included in this new edition.
Yes, that is a very important point. We shouldn't treat patients who have no help from, who don't gain anything from treatment with immunosuppressive drugs. So I think we are nearing the hour. There's just one question we haven't discussed, the IgA rapid progressive glomerulonephritis with crescents, what the recommendation would be for treatment. If Professor Floege can say a few words about that.
Crescents don't determine treatment. I think that's a very strong statement. We know that if you have isolated microhematuria, no proteinuria, and a normal GFR, these patients can have crescents. We know that if you take a kidney biopsy in an episode of macrohematuria, you will find crescents all over the place. And I don't think anybody would consider immunosuppression if you have infection-triggered macrohematuria. So it is always the clinical cause that dictates treatment. And the definition of Rpgn in IgA nephropathy is a clinical definition. It depends on your cause of renal function. It does not depend on the presence of 10%, 20% crescents. There's also no threshold. Of course, if you have 50% of crescents and the GFR is low, then you probably have one of these rare patients with, let's say, vasculitic IgA nephropathy.
Thank you for making that important point. So I think actually we are sort of ending this session. It has been extremely good, and we are all looking forward to reading the guidelines when they are published in September, and also very much looking forward to the app. I think that will help us as clinicians with the individual patient care. And I think that we have to end this by thanking every participant who attended the e-seminar, and you who want to receive credits for this activity, you and everybody else to stay connected for 1 more minute, and you will be directed to the short feedback survey that could take 1 minute. And that was very important for us to provide us with useful information so that we, with your help, can improve the quality of our future seminars. So thank you very much for the attention, and have a great evening,
you.
everybody.
Thank
Thank
you.
you.
Bye.
Thank you.